Thank you, Chris. And well, I don't know, it's still good morning, all of you. I'm sure I'm standing between you and lunch, but look, I mean, what brought me in this field, my background is public health, and I've been working on lifestyle diseases, diabetes, cardiovascular disease and stuff, and diabetes, and cardiovascular disease. And I was asked to join a multidisciplinary team for palliative care research, and this is when I heard about motor neuron disease like 10 years ago. And it struck me like it's one of those diseases that people haven't done anything wrong in their life and they get it. I mean, with the lifestyle diseases, we tell them they need more exercise, more nutrition, better nutrition, and really it's preventable in some conditions are. But for motor neuron disease, you look around, sometimes there are really very fit people, very sporty people. And this is what sort of drew me to this, to be part of researching this, this disease. And not only this, I really wanted to get better support for them while they're living so that they can have a good death. And of course, we know that the main thrust now of funding is for clinical trials, and that's really, really important. But again, we have to basically think that these people still have to live with the disease, them and their families, until a cure or some therapy has been found. And it still looks like it's quite a while from now. So I just like to, as WA health professionals, this is really important because this is what the MND Association does. They really help people live through the disease until we find a cure, and this is why the motto of most of the MND Association, until there is a cure, there is care. So without further ado, what I'd like to go through with you today is really how do you support the patient and their families from diagnosis to bereavement. And why I start with the diagnosis, this is quite interesting, and Dr. Rob Edis was part of the team that we investigated how the diagnosis is delivered and received by these people, is that in our smaller qualitative studies, invariably, and I'm not talking about Rob Edis here, but invariably the neurologists have always people saying negative things about them, in terms of how the diagnosis was delivered. So we thought, okay, well, let's get a national survey done and find out from the families, the patients, the carers, and neurologists themselves, how do they actually do it so that we get a bit more balanced approach to how is it done. So, and when I sort of read that the way the patient is told the diagnosis is recognized to be the first and one of the most delicate steps in palliative care, because it sets the tone for the rest of their journey. If they're totally traumatized when they know the diagnosis, it really doesn't put them in a good stand to actually be able to cope for the rest of their dreadful journey. So what patients and carers are saying when we did the survey, and I must say, we've had a lot of good comments, but I'm just really pointing here some of the negative comments. The neurologist was clinically thorough but uncaring when providing diagnosis of MND. He gave the brochure for information, told me I had 3 years to live, was left alone in the city 2 hours from home after diagnosis. If you've all seen the film that Rob was pointing at of Stephen Hawking, he was told the diagnosis as 21 or 23 by himself, and he sat in that corridor of the hospital for hours not knowing what to do. That's not on. This is not how, I mean, obviously that was ages ago, so this is what we're trying to improve now. I was told very bluntly about my situation and how it would basically progress. He said if I had any plans to do them now. I felt the neurologist was very insensitive, especially saying it's terminal. I hadn't enough time to comprehend what I had just been told. And this is from the partner, the spouse. The diagnosis was almost as bad for the partner. I was hardly considered at all, little or no empathy at all. The neurologist and other doctors just don't understand the needs of the patient's partner in order that he or she is better able to cope and provide support. So based on this, we asked the families and patients to rate the skills of their neurologists in delivering this diagnosis. So this is how it was grouped. 64% thought their neurologists, their skills were above average, and 36% was average and below. And then their satisfaction really mirrored this, sort of the same really proportions who were satisfied and not satisfied. So what makes a neurologist skilled and what makes a patient satisfied with the diagnosis? The time that the neurologist spends with the patient and deals with their emotions in that consultation is really very important, and both patients and carers said the same thing. So those who have spent like 50 minutes with the neurologist, they rated their neurologist skill excellent. And of course, as you can see, it goes down as the time goes down, there's sort of more poor skills there. Then we looked at the 6 SPIKES protocols, the SPIKES protocol that actually teaches about the best practice of developing, communicating bad news. And this is like across all bad news, not just motor neuron disease. So as you can see, the difference between the highly skilled neurologists, which are in yellow, and those who are average and below in blue, it comes very much to the emotion domain, which is the empathy. So those who have showed more empathy, of course, they were rated positively more. So this is the greatest difference. So responding with empathy to the feelings of the patient and family is number one. Sharing the information and suggesting realistic goals. This is where also the highly skilled and not so highly skilled neurologists do that. And exploring what the patient and family are expecting and hoping for, and making a plan and following through. I mean, this is a whole big study by itself, and I'll point you to the publications if you'd like to read more about it, but I don't have time to go through it completely here. Therefore, as health professionals, when you know somebody has just been diagnosed, you really, really need to know that they are going through a lot of bad emotions. They've been told you have a death sentence, So really they need support in identifying the best way to manage their negative emotions associated with the diagnosis, and normalizing them may help with acceptance. Patients and carers need to be supported immediately after receiving the diagnosis. This should include signposting to key sources of information, both in writing and who are the professionals that can help them, and acknowledging the individual's limited ability to take in the information at this point. They're completely stunned. So really the information needs to be given in small doses. And then prompt referral to the association. The M&D association make a hell of a lot of difference when people are referred at the diagnosis stage, because the psychosocial support that they get is really second to none, because we have these home visits that happen, and of course we have our loveliest M&D advisor who's going to talk to you about exactly the role after I finish from this. So anyway, so we've had quite a few publications. One focused on what the neurologist said, one focused on what the patient said, one on the family carers. I'll leave you to it actually. If you need the PDFs, please email Christina, and she's got all that. Right, so another cornerstone of improving the psychosocial care is looking after the family carers. Remember, these patients, the place of care for them is at home. The place of death, we'll talk about it later on. So they are vital partners in increasing the person-centeredness of health and social care systems. And this is where we need to bring back the approach to what people want, people need at the time that they need it. So the caregiver issues that they have when they have to look after somebody, of course, they've got the physical health that deteriorates. There's a financial burden here, which I'll mention a bit later on. Social isolation, their career interrupted, their jobs are interrupted, their quality of life interrupted. Of course, they're not sleeping well. But, of course, some of them, there's like this nice positiveness about it. They've got like enhanced relationships, they say. Again, managing the effect of lengthened period of anticipatory grief. So their grief starts way before the patient dies, because they've really lost the person that they've known, their husband or son or mother, way before the actual event itself. So they're in constant, period of grief. Again, the up and down of the course of the illness. The increased financial, social, physical, and emotional demands, dealing with dying as a gradual process, and the decision making and the treatments they have to make. This really weighs a lot on their conscience, and this is where the advanced care planning is very important for the patient to make those decisions and not leave it to the family carers, because they live with the guilt feeling afterwards that maybe they haven't done the right decisions for their loved ones. Again, we've got family disruption. The family dynamics changes a lot. And you know, it's just coping with the whole thing needs a lot of support with. So when we do every year the satisfaction surveys for the Motor Neuron Disease Association, because we're always trying to improve the services that we give amongst a really changing landscape, you know, of services. And of course the NDIS has changed things again. Over 65, under 65, like we've got all these silos now happening when we are trying to promote more person-centered care and more holistic approach to the person as a whole, not as, you know, like anatomy of their body is divided in who's going to basically help them with breathing, who's going to help them with communication, who's going, I think this has become so fragmented now with this new system. But anyway, it's our role as health professionals to be able to bring that whole person together's needs. So basically what the MND family care said, I think you traumatize, quite frankly, all the symptoms of trauma, numbness and shock and all of those things. And one of them said, I turned around and I said, give me a kiss. And I thought at the time he was denying me a kiss. But I realized now he had no muscles in his face to kiss me with. And I backed off and I thought, it's not that you've lost feeling for me, it's just that you can't. They should bring in euthanasia. You wouldn't put a dog through what MND does. I find it very difficult. It really rips you apart. Yeah, I mean, to actually go to this extent, it's a very traumatic thing on family carers. Now, the interesting thing, what this person is saying, they fear life or living with a disease greater than death. And this is so telling that, you know, we still need to basically change this. And they worry about their husband, family carer, how they're going to cope with them for the disease and after. And then bereavement support is actually not happening. So you go from one whole of army, basically, the house is totally inundated by, you know, service providers, and then you're just left alone and nothing, you know, nobody looks after them after this. So we really need to change, you know, what's happening now. So this is just something that when I did the social impact of caring for terminally ill people, it was like for all diseases. And I saw this, this report called Warning, Caring is a Health Hazard. And this shows basically the negative effects on health and life opportunities that people suffer in general looking after somebody with such diseases. But I'm always like, love solutions, and I try to find initiatives to basically help people. So I was part of this international collaboration on family caregiving at end of life. And we came up with this great intervention called the Carer Support Needs Assessment Tool. For short, it's CESNAT. Now, it's very simple, and you think, well, how come nobody has thought about it before? But it's fantastic. It's working really well. It's about really systematically reviewing the needs of the family carer from the practical point of view, psychological, spiritual, existential, and also asking them, what do you need to look after your loved one, which I think the services do well because everything is targeted towards the patient. And then the next set of domain is about what do you need to look after yourself as a carer. And this is why we're trying to change the culture of services to look, they have two people to look after, the patient and also the family carer, because often we call the family carers as the hidden patients. And, you know, they suffer drastically and then they're the next one to go, basically. So what we do with this approach, and this is a very much person-centered approach, and it is led by the carer, because it's the carer who tells the health professional, I need help in this or that, and we can talk about what. So basically, it's allowing them or giving them the opportunity to ask for help, because so many carers feel that they should cope. And if they ask for help, it's basically they're not doing a good job. And this is what we've done through this, set of projects that we've done, and the first one I've done was with Silver Chain, it worked really well. The impact of this intervention had reduced the caregiver burden and strain and distress for those in the intervention arm of the study who basically took part, and they had this intervention happening. So giving them that allowance to basically talk to the nurse instead of following the nurse to the driveway to her car and telling them their problems, the carers, we've allowed that space for them to discuss their needs with the nurse or the health professional. And so the nurse basically goes through the 14 domains. They tell the nurse what they need most help with in that visit. And then there's a shared action plan that happens, and then it's reviewed on a systematic basis. So no one falls through the gap like we are having now. It's been published, and we've done just a pilot study here with the M&D Association, and I've applied for more funding to roll it out across all Australia. And as you can see, the top needs of the M&D family carers in WA, knowing what to expect in the future, knowing who to contact, equipment to help care, dealing with your feelings and worries, having time to yourself in the day, and so on and so on, okay? So that is very important for a health professional like yours to know what are the core needs of family carers. So what happens is that once these conversations happens, the health professionals start talking to them, for instance, for the highest priority, knowing what to expect in the future. The discussions really flowed nicely into talking about end-of-life issues. Well, we know we have no cure for the disease, so we really need to start talking about these discussions earlier on. And unfortunately, palliative care services do not start from diagnosis, and I'll talk about this more when I talk about the palliative approach to care. But this tool has, in a way, introduced this end-of-life issues, advanced health directives, the role of palliative care really nicely, and in a not intrusive way, because of course when people hear about palliative care, they think it's the end. And yeah, we need to do something about changing the community perspective on this. So I just have time to tell you about one family carer who said one of the hardest issues is to discuss end-of-life care. And it is this form, meaning this SESNAT, focused my mind on the need to discuss this. And I ended up talking to people. I spoke to a counselor about end-of-life care as a direct result of going through the survey. So it's empowered people to actually take steps and put things in place earlier on. Now, one M&D advisor who took part in this, who's no longer with us, she said, I think it's interesting to see how carer needs change over time, and that their needs don't always follow the same trajectory as the person with M&D. Sometimes what I perceive as a very stressful time for the carer, they seem to sail through, whereas something minor for me at another time can unleash a great emotional tide for the carer. So you can never stereotype. It's the carer who needs to tell you how they feel at that particular moment when you do the assessment and put an action plan in place to help them. So, I mean, from the literature, we know they need coordinated support services, that honest and open communication that we are able now to achieve through this SESNAT. Respite, it's something we're still not doing greatly well here in WA, but the M&D Association, we've got it on our plans to actually do something about this. Financial assistance, we tend to sort of also help and see how we can provide this help for them. But even support, really, we need to do a lot of work still in this field. So on that, as I said, the loss and the grief starts really early because, again, you've got the losses that includes losing independence, mobility, self-control, confidence, body part and body image, the status that they had in the community and their families, the social acceptability, the inclusion in family or social life, the openness in communication, their identity, their role, and some of them said, you know, they start losing having belief in a good God. So a lot of the existential issues need to be done. So as I said, the anticipatory grief really, you know, refers to grieving that occurs prior to the actual loss. Common when death is expected, can begin from diagnosis, and both patients and family can grieve this expected loss. Bereavement assessment, we're still not doing this well. what we have now, and I'll run through the list. So we should conduct this, we always say this. It should commence prior to death to assess the risk factors, because sometimes the risk factors you have prior to death can really predict if they have a complicated bereavement experience or not afterwards. So a lot of things need to be resolved, not resolved, helped, before the death. And, we need to talk about social support, the social networks that people have around them to help them, their own personal history, the issues that they have surrounding death, and the pre-existing factors. So prior to death, encourage the family to spend time with the patient, explain all aspects of the patient care, communicate openly and honestly, keep the family informed about the patient's condition, provide emotional support, and encourage them to assist with physical care if they wish. After death, assess the bereavement needs, ask the family if they would like to assist or carry out last offices, allow family time with the patient after death, referral to counseling services if appropriate. So at the moment, this is the kind of intervention we have, not just for MND, for in general, if anybody dies, there's a phone call, there's a home visit, there's a memorial service, there is coffee morning, support groups, counseling. I had a pastor the other day telling me, I don't have many people coming to my memorial service anymore. And I said, well, what does that mean? You have to go with what the community needs, and the landscape is changing with what people need these days. So we did a national bereavement survey, which was really telling, and it really changed the landscape of how people are doing bereavement support now. And I'll just tell you quickly on this because, anyway, so it's published. I called it Who Needs Bereavement Support? And what it showed that bereaved people come under three categories. The majority are low risk, and they get their grief resolved with just support from their friends, family, and social networks in general. Top of the pyramid, about 10%. So the ones in black are the ones I could figure out from the literature, and this is what we got from our survey. And we managed to get to the next of kin who are bereaved through the databases of funeral providers. Because in this country, or in WA, you cannot get to the death registry and basically send surveys to people, unfortunately. But all my colleagues in Europe are able, the health department and the death registry help them access, to know the experience of people who have died. So it's very limiting to do this kind of research here. So I'm grateful for the funeral providers to actually have come to the play. It wasn't easy, they were very sort of hesitant at the start. Obviously, they've never taken, they've never had any research done. And so I started from Research 101 with them to actually bring them to why research is important and, the effect, the good stuff that can come back to the community. Anyway, so you have to think, outside the box when you want to get services to people and base it on evidence. So it's the middle tier here that's the moderate risk, who basically probably need not necessarily professional support at the top tier, but they will benefit from bereavement peer support groups and volunteer-led groups. And from the small studies that we've done with an Australian study here, we think the bereaved family carers for MND tend to be in the top tier. So they do have really complicated bereavement experiences, again, depending on how well they were supported or not during the caregiving thing. So that's why we are running nearly the same survey now, but for all MND bereaved carers in Australia, and we're doing this through the databases of all the MND associations. So that would be really good to find out where, the psychosocial morbidity of MND family carers in terms of their grief, their anxiety, their depression, and the family dynamics that actually happen during that time. So that's the small study that we run. So what people have said regarding, this is a general survey, as you can see, the ones who are at high risk are the ones who said they didn't have enough support. And then we looked at the clinical practice guidelines for the psychosocial and bereavement support for family carers. They were mainly for cancer. And one of the guidelines is that palliative care services should follow the bereaved family at 3 to 6 weeks and then again at 6 months. So what we were told is that only 50% of people are followed up 3 to 6 weeks. and about 25% as are followed up at 6 months. And then when we asked them how useful it was, well, it wasn't like an overwhelming positive experience, because some of them, they didn't benefit anything. They thought it was a blanket approach. They felt that the people who looked after them before death are not the same who are asking them the questions at bereavement, and they really wanted to have that continuity of support. That meant a lot for families, because I don't want to repeat the same story again. But even the calls that they had from the palliative care services, at 3 and 6 weeks, a different person rang them at 6 months. So they had to start all over again. Well, I mean, that's not really great for psychosocial support. And they felt that they were asking a question just because they had to do that, as this is their job to do it. It wasn't like person-centered and tailored to their needs. So this is what we're aimed to change. And this takes me to Palliative Care Australia, the peak body here. And so they're saying that the desire of thousands of gravely ill Australians to die without pain and surrounded by family is going unmet because palliative care services fall badly short. This is in the Productivity Commission report. So they will die in a way, in a place that doesn't reflect their values or their choices. Their end-of-life journey will likely be punctuated with avoidable or unwanted admissions to hospital, with the confusion, loss of dignity, and loss of control that comes with it. We really need to reduce hospital admission at end-of-life care. We really need to help have the services at home. We really need to bolster the capacity of the family carers to do this. And of course, when Rob said we have a high rate of MND sufferers who would opt for voluntary assisted dying, so the research are showing they don't opt for that because they have pain. They opt for that because they've lost their dignity. Dignity is so important, and this is what makes people want to just quit, basically. But if we had all these supports for everybody right from the start, we probably, we wouldn't have been in this conversation now about people wanting to end their life. But of course, it's their choice. This is what we say all the time. So that's why I really want to introduce you to an international concept now that's happening. And the research that I've done has really, really affirmed the evidence of this. Caring, dying, and grieving is everyone's responsibility. Us as a community. It's not the responsibility of health services. So when we looked at the 1,000 people who answered the survey, as you can see, 90% have basically relied on family and friend to resolve their bereavement or their grief. The interesting thing, the funeral providers came third on that list. That was the new thing that we didn't know. And therefore, this is where I was looking in the community, how do we build the social networks? So if the funeral providers are relied upon, and people said in the survey, we expect them to help them with our bereavement stage, or at least point us to who's in the community can help us. So act as a referral source as well, which was really interesting. After this comes the GP. But as you can see, we've separated the informal from the community from the professional here. So only the professional are the ones who are specialized to give bereavement counseling. And luckily, very few people use them. So basically, I'm going back to that triangle where those with really complicated grief, in a way, are not a lot, which is great. That's why bereavement is a community responsibility. It's going to affect all of us more than once. So it's like 100% prevalence, and we really need to be more active in this in our communities. So because of that, we really now have this, well, we've had it now for a few years, but it's really taken on the momentum really in the last 2 years. What's lacking from palliative care and the psychosocial support that we need to give is that social and practical support at end of life or for all life-limiting illnesses. So there's so much clinical services can do, and they're really focusing, because of the resources they have, symptom control, mainly physical symptom control, the comfort, all that stuff, which is great. But then again, we have a role to play into providing the social and practical support, and that's the compassionate community movement. So compassion communities, and it's an Australian researcher who started this, Professor Alan Callagher at La Trobe University, where I work part-time now. It's a way of thinking about how care is provided to the people who are dying. It relies on the identification and development of caring networks around the person and their carer, extending the concept of person-centered care to network-focused care. It's a natural part of life. It's about acknowledging that care for one another at times of crisis and loss is not only the task for health and social services, but it's everyone's responsibility. And this is just a picture to show you've got the person and the family with the illness at the core, and then you've got the inner network, outer network, the community. And this is what we're working through now, through La Trobe University, is bringing the informal community networks to work better with the formal health networks, so that we bridge that gap that people are basically falling through when they don't have any social or practical support at home. And we looked at what sources of bereavement support are perceived helpful. So obviously not everything is going to be helpful. So that was also very telling about how bereavement support should be delivered. Okay, last but not least, the M&D associations. I said they are really a cornerstone of this psychosocial support. Until there is a cure, there is care. And what our client said, I was poorly supported until I contacted the M&D association. And the M&D team took over and have been brilliant. Immediate referral to the M&D association should occur at diagnosis. Prior to that contact, I was in the dark as to what to do, who to contact. The information and support they provide make all the difference. They help me with all the support and how to cope with a tragic situation. So these are the sort of support that we provide. Provision of information regarding the disease, regarding services and support, emotional support, equipment provision and coordination, care coordination, education, access to counseling, end-of-life support. So, a whole wealth of skills there. And from the satisfaction survey that we've done for the last 3 years, as you can see, 80% satisfaction from both the carer and the patient. It could have been higher if we were able to reach our rural and regional patients and family carers. And this is why through this project that's going out to all regional, Chris is going to take it out to all regional areas. We started with Bunbury in March. This is the second one, but then after this we got Mandurah and so on. So stay tuned. Chris will tell everybody where the next locations are. So we got funding from Perpetual to actually now go there, provide the education, and also have our M&D advisory team, if they can go and meet the patients face-to-face instead of just, on the telephone. So when we ask them, what do you value of the aspects of the advisory service that we have, as you can see, it's high 80s and 90s in terms of being visited at home, the personal contact, the time dedicated to the visit, the proactive approach, anticipating the needs, the practical support, and the emotional support. Of course, there is room for improvement all the time, but this is fabulous feedback from our clients. Invariably, when we ask them about our team, they're professional, they're supportive, they're always there, and they're knowledgeable. This is across the board what we get from them. So, because we not only provide the practical support, we provide the emotional support for the patient and the family carer. Basically, I really wanted everybody to know about this, so we got it published, the results of the satisfaction survey, because, the health department is saying that we don't know if such community-based organizations are effective in helping the client. Well, yes, they don't know because nobody had published this good work that anybody does from the community organizations. And that's why this has been really useful to have it out there as a voice, to basically tell people that we are doing a good job, really. And these are our lovely 4 full-timers, M&D advisors, Bree, Abby, Leanne, and Joan. And Leanne is going to talk about her experience after I take some questions from you. That's it. I think done.